Good morning, everybody. I'll be talking on this topic, the case selection of surgical and interventional treatment in peripheral vascular disease. The incidence, as you see, if we take intermittent claudication or clinical features, it progressively increases to about 7.7 at the age of 75. But if we take non-invasive testing as the indicator, then it dramatically rises to 22% at 75, which goes to show that we should have more screening tests for patients with peripheral vascular disease. Now, whenever we select cases, we must think of the natural history. 2/3 of the patients remain constant with intermittent claudication for several years and only need a reduction of risk factors and maybe walking. 1/3 of the patients deteriorate, going over needing intervention. Whatever we do, the incidence of amputation has not reduced over time despite all the advances in our therapy. And I shall come to that point later. 50% of our patients have got cardiac problems, patients with peripheral vascular disease. Now, if we take clinical features as the criteria, but if we take non-invasive testing as the criteria, then that dramatically rises to 6 to 10-fold of patients having cardiac problems. Now, how do we select cases for PTA or surgery? Of course, we take angiography as the gold standard. The severity of symptoms, if a patient has got gangrene or has got rest pain, you would like to consider him. The most important thing is durability of the procedure we are doing. If a patient who's had angioplasty, we know the incidence at 5 years is 35 to 40%, and surgery is obviously 70-75%, we select that. So before we select something, we must have an idea of what we are going to find, what is the longevity of this patient. Of course, the site and length is important. The quality of runoff is exceptionally important, and many times we don't even care about this aspect. The skills of the various specialists, they depend upon the center. Therefore, what are the indications for angioplasty? Persistent limiting claudication, rest pain or tissue loss, or ulcers. Very poor surgical candidates, they are for angioplasty. Supposing you've got a patient who needs CABG, and you need a bypass on him, you'd like to preserve the vein, maybe angioplasty may be done. And lastly, if the vein is totally unsuitable, for instance, very thin, or it's varicosed, or it's thrombosed, you wouldn't like to select such a patient for surgery. What are the indications for surgery? Very long stenosis, for instance, whole of the long saphenous vein is blocked. You wouldn't like to do angioplasty perhaps in that case. Multifocal lesions, eccentric calcified lesions, and of course, if you have had a graft which is totally occluded, you wouldn't like to do angioplasty on that. Now, here are some statistics which you may or you may not agree with, but we find that if the initial success in angioplasty is always very high, but progressively it decreases, and that's something we must always remember. For instance, in this case, the initial success is 90%, but over time, if the distal runoff is good, it goes down to 57% in 5 years. And in 5 years, if the distal runoff is poor, it goes down to 44%. Comparing with surgery, iliofemoral bypass, 5-year patency is about 85%, whereas in iliofemoral bypass, it may go up to 90%. Decidedly, in the long run, surgery would be superior in this case. If you take the common femoropopliteal occlusive disease, in that case, again, the initial success of angioplasty is very, very high, about approaching 90 to 95%. But over time, we find that 2 years patency, or rather 5 years patency, goes down to 38%. Whereas compared to surgery, if we take a reverse long saphenous vein graft, we may find it 75%. And if you take a synthetic graft, it is 65% at 5 years, which again goes to show that surgery is preferable. Now, below knee results, if angioplasty is done, the initial results are good, approaching 80%, but 2 years patency is only 42%. And if we take a bypass using long saphenous vein, reverse long saphenous vein, at 3 years it's 80%, and at 5 years it's 50%, which again, surgery is preferable in this case. Diabetes, however, you find that because the outflow is very, very poor, because it's a small vessel disease, surgery is definitely not advisable. In these cases, angioplasty may be done along with if you give aspirin and warfarin. A study was conducted of 29 patients which showed that 75% of the ulcers healed in 12 months and below knee amputation or major amputation was avoided. The tissue oxygen pressure rose. Therefore, angioplasty is better. Now, if the graft has been put and it is occluded, there's a focal stenosis, maybe angioplasty may be done, otherwise surgery is better. Now, why do we have very poor long-term results of patency, long-term results? Because of intimal hyperplasia, and there's very little we know about it. The only treatment today which is coming out, people are still in the advanced stages, is verapamil. But otherwise, there's very little you can do about it. Progressive atherosclerosis is another factor which causes problems. Long eccentric calcified lesions, poor results. Occlusions have poor results than stenosis. Very poor distal runoff again has got very poor results. Now, comparison is very difficult of surgery and angioplasty. Why? Because most trials are multicentric and there are different protocols which are used at different centers. For instance, if we take the criteria of clinical features, in that case we find that gangrene is bad. If we take the clinical success like angiography or clinical improvement or non-invasive testing, it will be in different protocols. Again, if we see the patency, the degree of stenosis is important, or are you taking the pressure gradients? Therefore, comparison is very difficult. Why? Because most trials are multicentric. The capability of various performers in different centers is different. Techniques today are improving. For instance, this study, which I've written all this, was done in the late 90s. And today, already 10 years have passed. And by the time you get results, another 5-7 years pass. So techniques are improving every day. And what I'm going to tell you today is past, and therefore is no good, the study. And therefore, comparison is very difficult. Now, the most worrying trend today is that with advances in diagnosis and treatment, surgery has more than doubled, and angioplasty has gone up many-fold. But the amputation rate has not decreased, despite the fact that longevity of life has been considered, and the lifespan has been and the increase in population has been considered. Even then, amputation rate has not decreased. The reason which people have put forward is that there are many unnecessary surgeries, and especially angioplasties, which are being conducted all over the world, which are not required. Thank you very much.
Thank you. So it's important, this topic, to choose which technique, surgery or angioplasty, but maybe it's difficult to compare below the knee and femoral or iliac, because below the knee, you need not long-term patency. You need sometimes short-term patency to heal some ulcers, gangrene. So it's the difference. So maybe in a country like India, where you can find a lot of very high-grade stenosis and long occlusion, maybe angioplasty could be a good option, because it's difficult to propose long bypass, because the patency of surgery also for surgery is not good also. So maybe in the near future you have to go to this angioplasty, below the knee angioplasty, to heal a lot of gangrene ulcers. That may be the problem in India. Possibly. What do you think?
One question. There is a high incidence of peripheral vascular disease in coronary artery disease. Recently, in Indian Heart Journal, a study was published of about 180 to 200 patients, in which they found about 18% association. And these patients do not have intermittent claudication, as the incidence is not very high. So, but these patients, to prevent the progression of the disease and to prevent amputation, would you like to suggest to have routine investigations of ABI in all patients undergoing coronary angiography for coronary artery disease and selecting the cases? So what's your opinion about that?
Well, I think it's quite, we don't have enough studies to show that it is that much, but I personally believe that it is maybe as common as in the West. And we are going to see that. Because what 10 years ago coronary studies were, we thought there was not much heart disease. But today, it's rampant in this country. And I feel that in another 10 years, this is exactly what peripheral vascular disease is going to be here. With the advances in techniques, like all the catheters that are coming out, angioplasty techniques are improving. Maybe over time, we may find that that takes over. But what we are going to know today is what study we have got is 5 years retrospective, 10 years retrospective. So it is never possible to compare. But perhaps over time, we may find angioplasty is the answer for many things. But today, as I see it today, is that the surgical results in most cases are definitely superior.
That's accepted, but my point was whether we'd like to do ABI in all patients undergoing coronary angiography because there is a high incidence of peripheral vascular disease reported in India. There's only one study which I came across about that. So to evaluate peripheral vascular disease in all patients undergoing coronary artery disease, like the incidence of carotid artery disease is also very high in patients of coronary artery disease. So.
Yes, we should have that because that's exactly what I've said. When the clinical features were taken as the indicator, it was only 7.7%. But at the same time, when we took ankle brachial index, color Doppler studies, plethysmography, we found the incidence rising, same incidence rising to 22%, which goes to straightaway show that you do need, for instance, a patient comes to a cardiologist, I feel he should, even if the patient he's got atherosclerotic disease, he shouldn't think that it is only in the heart. It is all over. Now, if he picks these patients up early, which is very easy for him, he gives him a thing or gets non-invasive testing done, I think we'll get very many more patients whom in the long run we can prevent from amputations and various other problems like ulcers, breast pain, etc., gangrene. We can do all that.
I'm sorry for the interruption, Mr. Chairman. We have totally run out of time for the discussion. May we request to kindly move on to the next session. Thank you very much, gentlemen.
Thank you.